So the next session is one that we do get a lot of questions about, and we had some questions come up earlier, so I hope some of you have stuck around: genetics, prevention, and you. So in our session tonight, we are going to highlight the impact of learning about your genetic makeup, both on the care of those that are diagnosed with ovarian cancer, but also the impact that it has on family members. Genetic testing, we know, can provide additional treatment options for those living with ovarian cancer. As well, it can provide prevention opportunities for other family members that might have inherited the same genetic mutation. So I am pleased to introduce you to our panel this evening. And throughout our discussion tonight, you will learn more about each of them. First of all, we have Sherry Natashak, and Sherry is a Teal sister joining us tonight from Port Coquitlam, BC. We also have Sherry's sister, Arlene, Sherry's niece, Nicole, who is also Arlene's daughter, and they are both joining us from Saskatoon. We have genetics counselor, Andrea Harish, who is also joining us from Saskatoon, and Previver, Noreen Rosenberg, is joining us from her home in Toronto. So welcome all of you, and thank you so much for joining us tonight. Andrea, I'm going to start with you. So we'll get you to just set the stage a little bit. And can you start by just telling us a little bit more about genetics counseling and why it's so important?
Yeah, thank you to Ovarian Cancer Canada for inviting me tonight. I'm very happy to be here. I do want to keep this quick because I think the beauty of this session is going to be the other participants. But very briefly, genetic counseling is a medical specialty. I'm part of an allied health, so I'm not a physician. And there are a number of hereditary conditions that can affect people throughout their entire lifespan. And my job really involves meeting with families who may have a hereditary condition to help them understand what the possible causes could be, to understand different tests that might help to find out if there's something genetic. And this is really, really important for ovarian cancer because we do know that 1 in 4 to 1 in 5 women with ovarian cancer will have a hereditary predisposition that contributed to their cancer. And so my job is really, as I say, to meet with those women and their family members to help them understand different genetic tests. And when the results come back, help explain how that might be helpful for family members.
Okay, so before we turn it over to Noreen, can you explain to us what the term Previver means? I used it in my introduction, and maybe not everybody knows what that word means.
Yeah, it's a term that's been around. I believe Sue Friedman was the woman who coined this term, and she did it to it's related to a survivor. So it's the kind of other side of the coin of a cancer survivor. And it's meant to recognize that there are individuals who have a predisposition to cancer who may not have developed cancer. And it's to highlight that group of people has unique needs that is maybe different than a cancer survivor's needs. Some of them are similar and some are different. And so that is the term that many people with a genetic predisposition may use to kind of identify with.
Great, thank you. And I know when we in our pre-conversation as well, kind of like the term survivor. Some people love it and some people don't love it. So for the purpose of this, that's what we're going to use for our session tonight. So Noreen, before I get to you, I'm just going to take a couple minutes here just to provide a little bit more information about the most common types of genetic mutations that are associated with ovarian cancer. Now, we know that there are many more, but for the sake, again, of this session, we're just going to touch on the most common ones. So in the general population, about 1.4% of women will develop ovarian cancer. So by contrast, for women who have inherited BRCA1 genetic mutation, their lifetime risk of developing ovarian cancer goes up to between 39 and 44%. And women who have inherited BRCA2 genetic mutation, their increased risk of developing ovarian cancer goes up from about 11% to 17%. And we know with these genetic mutations, there's also an increased risk of breast cancer. So for the BRCA, again, in the general population, it's about 13% of women who have a lifetime chance of developing ovarian cancer. So for a person living with a BRCA1 genetic mutation, that risk goes up to between 55 and 72%. And a BRCA2 mutation, that risk goes up between 45 and 69%. The last one that I'm going to talk about is Lynch syndrome. It is the other major cancer susceptibility syndrome that can increase lifetime risk of ovarian cancer for up to 20%. Lynch syndrome also increases risk for endometrial and colorectal cancers, as well as others. So now that I've kind of taken a couple of minutes to explain that, I would love to introduce you to another panelist, Noreen Rosenberg. Noreen is a family physician, a Previver, and she resides in Toronto. Noreen, you were very young when your mom died from ovarian cancer. Can you share a little bit of your story with us?
For sure. So thanks so much for having me, and welcome everyone who we can't see, and hi to my fellow panelists. I'm Noreen Rosenberg, and yeah, I'll start by telling you a little bit about my, I guess, journey to getting here. And that started when I was about 9 years old. My mom, Lynn, was diagnosed with ovarian cancer. And so, you know, that obviously had a huge impact on my life. I have two siblings. So it was a big part of our childhood, her diagnosis and treatment and getting into remission. And then unfortunately, when I was 12 years old, she had a relapse like 3 years after remission, and unfortunately ended up passing away from the ovarian cancer. And during her diagnosis, she did end up going through genetic testing. And that's when we found out that she had the BRCA1 mutation. So at the time, you know, the genetic aspect of the disease, it was something I knew about, but, you know, not a big thing I was thinking about when I was 13, more so obviously processing like the loss of my mom and going through that for many years with our family. But I was just talking to my family today, and they were saying she used to do, like, she did some breakfast talks when she had recovered the first time, and really believed in, you know, connecting with the ovarian cancer community and advocating and spreading awareness. So thinking of her today being here. Anyway, so basically fast forward to my undergrad, and Alicia Tone, who's organizing tonight and invited me here, ended up, we met when I was doing research, and I actually ended up doing research at Ovarian Cancer Canada on my first years of undergrad. So she was actually the PhD student who I worked under and got to do research in ovarian cancer. And that's really when I started having more discussions with my family, my older sister, about the BRCA1. It was something I always knew we'd have to sort of think about when we got older, when it became more relevant. And when I worked at OVCare, I kind of learned more the medical side of things. And so that's really when I started thinking about timing and when would I want to do the genetic testing. So it took many years. My sister was the first one to get tested. I think about 4 years ago now. She ended up being positive for the BRCA1 mutation, and she started her screening process and stuff like that. And then I always eventually decided around age 25 was when I was going to get tested. So I ended up, unfortunately, also testing for the BRCA1 mutation, which is why I'm here. And yeah, I think later on in this panel, we're going to talk a bit about, you know, different decisions we've made down the road. And I'm happy to answer any questions people have. And I'll share a bit more about after finding out I was BRCA positive, you know, what I've decided to do and future things I have to think about.
Thanks, Noreen. And you'll see in the chat that Alicia has said you were the best student ever. So thank you, and thanks for joining us. Just a quick question before we move on. Did losing your mom at such a young age impact your decision to pursue medicine as a career?
Yeah, I definitely think it was a factor. And I think just being young and, you know, being closely connected with the medical system, seeing my mom's relationship with her family doctor, her oncologist, her surgical oncologist, and I guess just seeing how much like health can impact someone and their family definitely made me, you know, passionate about wanting to have a career in that area, so that I could, eventually be able to help people who kind of went through what we did. And yeah, now I'm practicing and very happy I made the decision. So,
and your patients are certainly lucky to have you. So thank you. I'm going to now introduce you to Sherry. Sherry is an RCMP officer from Port Coquitlam, BC, and she was diagnosed with ovarian cancer in 2019. Like I mentioned before, Sherry's sister Arlene is also with us tonight, and Sherry's niece Nicole joining from Saskatoon. So Sherry, can you just start off by telling us a little bit about your family history and your diagnosis with ovarian cancer?
Sure. I want to thank everybody for joining tonight. And yeah, this is really important because I think the more people that we can spread the word, diagnosis and treatments, I think it will just help immensely for other women down the road. So I'm 57 years old, born in Melfort, Saskatchewan. I currently live in Port Coquitlam, British Columbia. I was 54 years old. 54 years old when I was diagnosed with stage 3 serous ovarian cancer on June the 5th, 2019. And at that time, I then started doing weekly treatments. So I did 3 cycles of carboplatin and paclitaxel and completed that, and then had a complete hysterectomy and debulking on October the 10th, 2019. And then I did more chemo, another 9 more weeks, 3 cycles of the chemo, finishing in January of 2020. I'm one of 4 daughters, and our family history is direct in line with me. Our father had prostate cancer, was diagnosed in his mid 60s and got treatment and has been NED since then. His father, our grandfather, was diagnosed with prostate and colon cancer as well. My father's sister, so our aunt, was diagnosed with ovarian cancer at I think in her mid 40s, and got treatment and has been NED for decades. Unfortunately, her daughter got breast cancer and passed away here in 2020. So I first learned of genetic testing right out of the gate when I went to see the gynae oncologist, the surgeon, and in talking about my surgery, tumor removal and everything. And she was just very inquisitive and started asking me about my ethnicity. I'm 100% Ukrainian, both parents. And so she then started asking me about other family histories. And so seeing that there could have been a direct link between father, cousins, aunts. And so she's like, well, what ethnicity are you? Said Ukrainian. And so then she started to explain to me that Eastern European countries have a higher propensity for BRCA1 cancers. So I'm like, okay. So she then suggested getting in contact with a genetic counselor. I then saw my oncologist. And again, she was very switched on as well. And again, started the conversation about the genetics. And she then directly got me set up with a hereditary counselor in Abbotsford. I live in Port Coquitlam. So everything was done over the phone. So I ended up getting the forms for the family tree history. And at that time, because I was already starting my chemo, I then had awesome support from my family. And I just basically said, you guys need to deal with this. So I forwarded all the forms. Arlene spearheaded everything because I'm the only one in Vancouver in British Columbia, and everybody else was back in Saskatchewan. So basically threw it to them and said, here, you do that. And Arlene said, you focus on your treatments, you focus on getting healthy. And so I really just waited for them to complete all that and get it back to me. So once that got back, the hereditary counselor then sent me to go get my blood test, which was then sent off to San Francisco. And it came back that I was BRCA1 positive. I think I recall I got the news just before around the time I was getting my debulking hysterectomy surgery in October of 2019. And so then knowing that, then again, I just called my family, said I'm BRCA1 positive, and Arlene can explain, she's a nurse. So I threw it back to her and said, okay, you deal with all the family there because I'm here and I'm still getting my treatment and I'm recovering from my surgery. So basically from there, well, I then finished my treatment, like I said, in January of 2020. and then was started to take olaparib, the Lynparza olaparib. Pretty much after that, was on it up until just recently, about a week ago. And so yeah, I've been NED up until about a week ago, and then a CT scan just came back here last week that indicated I've got some abnormalities, and so I will be starting up conversations with the oncologist here on November the 22nd. So I'd also been scheduled for a bilateral mastectomy 2 days from now, November the 10th, but because of the anomaly now in the CT scan, I just go back to square one and figure out what treatment options I have. And then the bilateral mastectomy is still kind of on the table, but that'll just get put down the road a little bit until I know exactly what's going on with treatments and such. So that's where that kind of all played in very early in my with the surgeons and with my oncologist.
Thanks, Sherry. You said two, and I just wanted to confirm here too. So your the BRCA one was inherited from your father's side, correct?
That's correct. So
yeah.
There was no testing back even when he had his prostate cancer. So basically, I was the first one to get tested in our family. And immediately once I got the results, like I said, I immediately let them know, because it was detrimental that then my other three sisters were to find out. So like I said, I then threw it to Arlene, and she's the one that spearheaded the rest of the family getting tested. And Arlene contacted my hereditary counselor out here, Stephanie, who then got her in touch with Andrea. So they can speak to that part of the Saskatchewan connection with the whole testing and everything.
Thanks. I'm glad we pointed that out, because I think that's a common misconception as well, is that the genetic mutation is carried by the female and not necessarily the male, but that's not true. So thank you for sharing that. You also had mentioned your heritage, and I just wanted to say as well that yes, people with an Eastern European, French Canadian, or Ashkenazi Jewish background could have an increased risk of inheriting the BRCA mutation. So Arlene, I'm going to pass it over to you now, and thank you so much for joining us tonight. And in my conversations preparing this sessions with Sherry, she joked with me that you two were Ukrainian twins because you were born just 12 months apart and have an incredibly close bond. So can you tell us a little bit, Arlene, about when Sherry had kind of asked you to reach out to family members, and tell us a little bit about that process and how people reacted to that? Families have obviously different personalities and different ways of reacting, and I would just be curious to know how that process went for you.
Sure. First off, thanks for having us tonight. So when Sherry first told us, I wasn't surprised. We figured there was some sort of genetic link there. There had to be with the high incidence of cancer in the family, with our aunt having ovarian cancer. So I wasn't surprised. So I did speak to the genetic counselor in BC, and then from there, kind of worked our way into getting testing here in Saskatchewan. Did have to go to my family physician for a referral at the time, and was referred to the genetic counselors in Saskatoon. And we were lucky enough to have Andrea, who was our genetic counselor. So she helped us through the entire process. It was a matter of us all sitting down with her explaining what it meant. If the results were to come back positive, and if we wanted to be tested, and everyone in the family was tested, including my mom, just to see for sure, to rule her out. And it came back that our dad was positive. And so I also came back positive, as did 2 out of my 3 children. And one of them here tonight, Nicole, and then my son, Michael, as well. So hearing the news, I wasn't surprised, just because, like you said, Sherry and I are Ukrainian twins. So I wasn't surprised that I was positive for it. And Andrea was very good about explaining what that meant for me and my family. And what it meant was looking at prevention. I think prevention was the biggest thing. And for me, knowledge is power. And if I'm able to use that, so being a nurse, I'm all about getting things done and from the medical perspective. So I myself have had some risk reduction surgery and that, and will continue and finish up here in November. But what it meant for the family, for me, a lot of guilt on my part, knowing that I passed it on to my family, my children. That was a big thing that I still struggle with. But as for the rest of the family, we did involve the aunts and uncles, and we left it up to them to decide whether or not they and the rest of their family wished to be tested. I know some had and some have not, but that was, their decision to make.
So thanks, Arlene. Now you have already started the process also of a preventative double mastectomy. You had, like you said, prior to removal of the fallopian tubes and ovaries, and now have just started this process. Can you tell us a little bit about what factors, I guess, played into that decision? It's obviously not an easy decision to make.
Well, just the fact what Sherry was going through herself, having to see what she had to go through, and the fact that we lost a cousin to breast cancer at the young age, early 40s, that was huge. And the fact that my chances were high, like really high of some of what time in my life when I could get cancer. So, and if I could prevent it, by all means, I was going to prevent it.
And so, Arlene, you have mentioned that you have 3 children, and 2 out of the 3 have inherited the BRCA1 mutation. And Nicole is here with us tonight to share her perspectives. And thank you, Nicole. I know you are a busy mom to a 1-year-old or an almost 1-year-old. So thanks for taking the time tonight.
Yeah, of course.
Now, you're obviously at a different stage in life than your mom when you found out that you had inherited the BRCA1 mutation. Tell us a little bit about the impacts that receiving that news, I guess, had on your family.
Once again, thanks for having me. It's nice to see everybody. The big thing for me was the question in my head right away was family planning. I knew I wanted to have a family. And my question was, well, where does this now fit into my plans? And how can I go about incorporating, knowing I have this, into my family? My original plan with my partners, we wanted to wait until our early 30s. So 32 seemed ideal for us. But with the news of the BRCA1, we decided that it was best just to go ahead and start our family a little sooner, because for me, I didn't want to miss out on the opportunity to have any children. So ideally, so that's what happened. We ended up having our son last year. And I wanted to have my children too before I went through the preventative surgeries, because I am planning as well to have everything taken eventually. So yeah. I wanted to make sure I had the family done. So when I was faced later on, I could just cut it all out.
Big, huge decisions and big impacts on your life there. So what kind of, now that you know you're BRCA1 positive and that you do plan to have preventative surgeries in the future, what kind of follow-up or monitoring do you have now?
Currently, because I am breastfeeding, I haven't had any screenings for my breasts. But eventually I will be doing every 6 months. I'll go for an MRI and then I will go for a mammogram just to ensure that there's nothing growing. And then currently too, it depends on what doctor I talk to, whether or not I should be getting screening done for my ovaries. So or my area there. So right now, for my own sanity, I like to go every 6 months. So I go to my family doctor and I ask her to book me an appointment. And she's been very good about booking me that appointment. But I have talked to other doctors who said that there's really no point in doing anything right now for me. But like I said, for my own sanity, I like to make sure I know what's going on with my body.
And Nicole, when we were planning for this session as well, you had mentioned that at the beginning of when you found out that you carried the mutation, that you had a hard time for people to take you seriously, and you had tried to book some appointments, and tell us a little bit about that and the need for self-advocacy.
It was my first time I was going for my mammogram. So I recently found out I had the BRCA1, and I was nervous going in. I didn't know at the time that there was normally an age that you started these screenings. So when I called to book my appointment, the lady on the phone didn't want to give me my mammogram. She was fine with the ovaries, but she kept saying like, well, we don't typically do it for someone this young. It's not done this way. And I kept reassuring her, I have my doctor's requisition, it's set in stone. So we went back and forth. And when I hung up, I felt like I had the appointment set up, but upon arriving to the office, they told me I wasn't actually booked for the mammogram. So I called my mom and she said, no, make sure that you tell them that you need to be getting this done. You're BRCA1, you're high risk. So I went back and I did talk to the ultrasound lady who was giving it. And she said, I'll go talk to the radiologist. And once the radiologist found out, then they put me in for the mammogram. So it took about 2 additional people to finally be seen for that. So I was a little, I don't even know how to explain it. I was a little shocked by it, especially because when you have that requisition, you're going in thinking like, okay, this is all set in stone, but it wasn't. So.
And nice to have such a great support system. And I guess that just relays the importance of having a great team around you as well, having your mom there to help you through that as well.
Yeah, it's been as bad as it is. My Aunt Sherry, kind of my idol right now too. It's just phenomenal that I have this in my life, because I have 2 other people that I can see go through these stages. And it's even my mom right now, she's going in 2 weeks, and I'm so proud of her that she's going. And it's nice because then when she goes through it, I'll be like, oh, hey, you can help me coach me. So it's nice having supports.
But like you said, knowledge is power, right? Shared knowledge is power as well. So Noreen, I'm going to turn it back over to you now. You are close in age to Nicole. So again, at different stages. Can you tell us a little bit, and you've made some decisions on risk reducing surgeries as well. So can you tell us about some of those decisions and some of the factors that went into making those decisions?
Yeah, for sure. So I guess something we sort of spoke about when we all talked earlier was just to preface all this with, there's really no like one size fits all or one decision that works for everyone. That's why people like Andrea exist, and family doctors and family people just to talk to, because, there's no right decision, and there's lots of like different paths you can go down in terms of prevention or screening or surveillance. And it's really, I think, so important to take the time to process and think about that before you jump into any decisions. So yeah, for me, that journey sort of started when I was young, and even as a teenager, always thinking about, okay, this is eventually something I'll have to think about, even the choice of getting genetic testing, whether you want to know or not. So it was something I knew I wanted to do, especially just, I think, as some people here have mentioned, like either having family members go through cancer diagnosis, I think really shows you the impact it can have. And, for me, thinking about if my mother had the chance of knowing she was BRCA positive, I think, she had finished having her children at 36, and she was diagnosed with ovarian cancer at 45 and didn't do any childbearing after that. So I think of things like that, and hopefully for us and Nicole, and, we'll be able to make decisions and prevent what has happened to my mom, and diagnosis like Sherry and other people who spoke tonight, because we know ovarian cancer is just such a horrible disease. So my sister got tested first, and then I got tested around age 25 when I knew there were like options that I could start screening. And I think we spoke about this as well before, but it's interesting, like you'll see in every province in Canada, there's actually like different guidelines on screening for women with BRCA1 and other high-risk women. So in BC, where I did my genetic counseling, they mentioned I would have started breast screening if I wanted to at age 25, or in Ontario, the high-risk physicians I was connected to, they recommended age 30. So at first I was gonna potentially wait till 30. I was kind of having those back and forth discussions. And then my sister ended up having like something found on one of her screening MRIs, and she ended up going for biopsy and was diagnosed with ductal carcinoma in situ, so sort of like stage 0 breast cancer. So that kind of fast-tracked her decision to have a bilateral mastectomy, and she was like 30 at that diagnosis. So that really pushed me to decide to go ahead with like a prophylactic mastectomy earlier than I might have done otherwise, because we don't have any early breast cancer in our family prior to that. So I kind of got the ball rolling and asked for referrals to like the high-risk breast screening program and high-risk clinic, and then to plastic surgeons, general surgeons. And I ended up having like the first step of my surgery this past March in 2022. And unfortunately, I've had a couple complications from the surgery. So I'm 3 surgeries in and have 2 more to go. My next one's in just under a month. So that's definitely been difficult. And but yeah, I'm just, excited to get this part behind me, and just being at events like this and talking to people reminds you that, you're doing this for a reason. And then, yeah, in terms of like the ovarian cancer prevention, that's something that, for now it's kind of on the back burner, and something I'll think about when I'm in my early to mid 30s, and once I'm kind of ready to have children, and try and decide timing around that. My sister just had her first baby about a month ago, so that's really exciting. And I think we were counseled around 5 to 10 years before our mom's diagnosis would be when like the risk reducing removal of the ovaries and fallopian tubes would be recommended. So, definitely like impacts thoughts around having children and stuff like that. And then other things to think about also, now there's options to do like embryo selection. We have a cousin who is a male who has the BRCA, and him and his partner are in Europe, and they actually like the country will cover it. So they ended up selecting embryos without the BRCA1 mutation. So something my sister had also thought about. She ended up deciding to get pregnant naturally. And again, there's like no right way to go. Both are, have pros and cons, but just all sorts of things I think about and reflect on. So that's kind of where I'm at these days.
And so you, like Nicole talked a little bit about support, and I don't know if lucky is the right term or not, but had your sister kind of going through the process, maybe one step ahead of you, really just highlighting the importance of support on this journey that you're on.
Yeah, definitely. And I think it's one little blessing that comes out of these genetic things, that unfortunately we're so disappointed that we both had to deal with having the gene, but also that we can be there for each other and support each other.
And congratulations on your new nephew. So as a family doctor, Noreen, can you tell us a little bit about, what should family doctors know first off about ovarian cancer, and just how important the role of family history plays out in this?
Yeah, so as family doctors, you're sort of the first line. So you're the one usually seeing undifferentiated patients with new symptoms. So part of our job for almost every presentation is like a risk assessment and looking at people's risk factors. So, just highlighting the importance of making sure any new patient you're seeing that you're always asking about a family history. And if you're taking on new patients, you're always exploring that, documenting it, having it on your chart so you can look at that when you're assessing a new issue. And I think, of course, just knowing if someone is positive for genetic mutations, that usually they're higher risk of having cancers earlier. So having a higher index of suspicion in younger patients to have that on your differential. But yeah, it's definitely a big challenge. And as we know, ovarian cancer symptoms are like extremely vague and general and really hard to pick up early. So I think just always, like listening to your patient, investigating if someone says there's a significant change, and I think knowing like the high risk clinics to refer to, or genetic counselors to refer to, or knowing if it's out of your scope, to connect with someone who can help like further investigate. But definitely a challenge. And yeah, something that I think we'll all continue to hopefully learn more, and hopefully one day we have screening for ovarian cancer. But yeah, unfortunately right now there's no, I guess, evidence-based screening tool, which is challenging. So we just have to kind of go off of new symptoms and looking into things.
Great, thank you. Andrew, I'm going to throw it back to you now. Can you tell us a little bit about any recent advances in genetic counseling and testing that have allowed more women with ovarian cancer to access these services?
Yeah, I think education and health provider education is one of the biggest pieces. So there's now many statements in multiple continents saying really that genetic testing and genetic counseling should be offered to all women who do have an ovarian cancer diagnosis. And I think that's one of the biggest, most important things. But there's also been advances both in the way we do genetic testing. So the BRCA1 and 2 genes that you mentioned were discovered in the mid-1990s. And at that time, we could only really look at those 2 genes and not even fully. And now I would say that most women undergoing testing are probably offered a panel of genes. And I haven't been able to see all the questions, but there are other types of gene mutations that have been popping up. And usually women will be offered kind of a full panel so that if we're missing a BRCA1 or 2, or there's not a BRCA1 or 2, there may be something else in that family. And again, one of the other new kind of advances is that most genetic testing to look for inherited causes is done on a blood sample. That's usually the typical sample, but there's also new advances to do tumor-based testing. And that has additional advantages in finding BRCA mutations that are not always inherited or being passed down in a family. But some women with ovarian cancer just have one that's happened by chance in their tumor. And that comes back to the treatment, even hearing this drug, this olaparib or PARP inhibitors or Lynparza. And we do know that that having a gene mutation may make you kind of a candidate or respond better to certain targeted or personalized therapies. So that's another kind of major advance that we've seen.
I don't know if you want to touch on, we've talked about it a little bit before too, about how things differ so much from province to province and region to region, and even as we've heard from cancer center to cancer center.
Yeah, and I think we're all striving to do better with that too. I really did relate when we were prepping for this session about just kind of the struggle to get information and maybe to find out what is right for you. So timelines even about when to access genetic testing and all of that is different. And I think even as much as we strive to have some consistency, I'm sorry if you guys can hear a pup in the background there, as much as we strive for consistency, I think it's going to be important to be able to deliver a personalized approach. So I know within the field of genetic counselors and in Canada, we definitely all talk within our provincial groups and we try to work together, but we recognize that healthcare in Canada is mandated provincially, or the decisions are mandated provincially. And so there's always going to be a bit of a variation. And I think, going forward, it's good to know, yes, what your relative did, and just to go in knowing that it might be slightly different, but all of it is geared to giving the best care in the end.
Great, thanks. That's a tough one. Sorry to throw that one.
No, it is. It is tough. I don't think there's a perfect one size fits all, but that's okay too. It also means that there's room for personalized approach, but we can always do better too. So stories like Nicole's, for example. It's always hard to hear that somebody has all the right information and goes in and still has to do advocating. But we're all on the right trajectory, hopefully.
So I'm going to just throw back here, Arlene, to you and Noreen, because Arlene, you have a son who has also tested positive or has inherited the BRCA1 mutation. And Noreen, you also have a brother, and I'm not sure, you can maybe tell us if he's been tested, but just Arlene, does your son who has tested and inherited the mutation, is there any special follow-up that he does now knowing that he's positive?
It wasn't until we had this conversation actually that I asked him, and I just took it for granted that he was. But at this point, he hadn't been. So we did sit down and have a conversation and did talk about, when he would start with the prostate exams and also with some breast screening as well. Although breast screening isn't as prevalent in men, I did impress upon him the importance of it just for self-breast exams and things like that. So I did ask him if his doctor was aware he was BRCA1, and he hadn't even informed his doctor that he was BRCA1. So impressed upon him the fact that, yeah, he should go ahead and speak to his physician and let him know, so that they could start with any preventative type testing and things like that.
And Noreen, you have a brother also?
Yeah, I have a brother. He's 35, and he has not yet gotten tested. I think he's in the process. And yeah, I think one of the things a lot of us looked into before getting tested was like looking into life insurance and different types of health insurance just before we knew about our genetic predisposition. So I think he's in that process right now. But yeah, even though technically like insurance companies aren't supposed to discriminate against you for that, that was sort of what we all decided. So just another thing to think about.
Yeah, so many decisions we just never think we're going to have to make or have to think about, right? That are kind of thrown out there all of a sudden. So I just wanted to, Noreen and Nicole, you guys, when we were chatting before, also had some great tips and advice for people who are just learning or just finding out that they've inherited this mutation. Can you share some of those tips with us? Collecting just about making decisions and things like that.
Sure, maybe I'll jump in, Nicole, and then I'll pass it to you. So I think some of the things we talked about was that, it can be a hard decision. Like it took me many, many years to figure out like what age I wanted to get tested, even for the BRCA1 gene. So what we kind of discussed was that, even just getting the referral to a genetic counselor, or I guess now a lot of people don't need referrals, self-referring, just getting that appointment to gather information, and also be connected in the system is so important, because even just getting those first appointments or getting tested, sometimes that can take several months. So it's just good, especially in our healthcare system, to kind of get the ball rolling on that, and just knowing that if you make these appointments, you don't have to actually go ahead with getting tested. Or if you do have a mutation, get appointments with specialists to learn about surgeries. It doesn't mean you have to get the surgery. So I think just given there's quite a bit of wait time in our system, for me, it was helpful to ask for these things in advance of maybe when I was ready for them or when I wanted to know, so that by the time I made those decisions, I had access to it and I had more time to think a lot about my different options and didn't feel rushed into making decisions. So I think those were some of my suggestions, is just, gather all the information earlier if you can, so that you have time to make your decisions.
Yeah, I would 100% agree with that. When it came aware that my Aunt Sherry had BRCA1, I actually wasn't able to get tested until my mother came back positive. And so I had about almost a year to wait for my mom to find out. So I had a lot of time to process and think about what I was going to do. There's no doubt in my mind I was going to get testing. And when it came down to it, I was actually a little frustrated. I couldn't get it done sooner. So that's one thing. When you do put in the request, it will take a while. So you have time to think about it. But if you need it done, it's better to have that appointment booked, in my opinion, and from personal experience. And that way you can go ahead and make those options. I have the option at least there if you do need it or decide you don't want to take it either, just because it is so long to wait sometimes.
Right. Better to be on the list and take that time before making that.
Mm-hmm.
Now I'm just going to ask one final question, and I'm going to ask this to Sherry and Arlene. Every family is different. We know every family has different dynamics. Is there any advice there's people that are listening in tonight that again are just finding out maybe that they're BRCA positive or that they have a genetic mutation and they need to share this information out with their family? any advice you can give to people tonight in disseminating that information out and in doing that?
I think for myself, because Arlene and I are close in age and we have a strong relationship, and because of her profession and my profession, we just are very pragmatic. So when I had first told her, and also because of the geographical distance between us, I'm in British Columbia, she's in Saskatchewan, all my family's back in Saskatchewan. So in Arlene's medical background, it was very helpful. We also knew that our older sister, who's very, she's very sensitive. So we knew that she would probably need more support once the testing happened, that our dad came back positive. Then I actually asked Arlene, please, can you just go there and support her? So that I, again, was out of my hands because I was still, again, getting my treatments and everything. So it helped to have strong support and family members that you lean on those members. And especially if you're in treatment, it helps take some of that stress away from you, because you knew that I knew then they were getting good care. I trusted the genetic counselor here in British Columbia. I knew that Arlene had reached out to Andrea and everyone was getting tested there. Other aunts and uncles, it was up to them what they wanted, but our family knew that we wanted the answers. So that's just kind of who we are. And we did, we went, and we still, this week, Arlene's decision to go get her surgery was in limbo. And I said, please, I really wish and hope that you go do this, because if anything learned from my lessons is that you need to do this. And eventually, hopefully, I will get that opportunity once I get all my medical stuff in order. But it's important to, again, yes, to rely on other people's strengths. And again, if you've got the opportunity to go and get these preventative surgeries, please do. Arlene, anything to add?
Yeah, we basically, I reached out to my mother. She was the phone tree. She had everybody's phone numbers. So it was a matter of then contacting them and letting them know that we've been tested and my dad was positive, and sending them the letter then with the kinship number and that information, and just telling them, you know, who they need to contact. So they need to contact the genetic council, the genetic department from the university in Saskatoon here. So it was a matter of getting that information out to them just through phone calls and that. So yeah, and then we kind of left it in their hands. We did have one uncle who was tested and he was negative. So then the remainder of his family didn't have to be tested. And one uncle in Vancouver chose not to. And so none of his family were tested. Another one in Saskatchewan here had said he was going to get tested, but I don't think to this day that they still have. So but I just know we as a family had decided that we wanted to have the answers, and we wanted to know what we could do if we did have it.
I love Sherry saying, know what your personalities are and play to those strengths. And I know she called you the superstar in the family for reaching out to everyone. So thank you for that. And I want to thank you all on the panel for sharing with us tonight your experiences. We've got some questions now. So if you're all okay, I'm going to ask a few questions and we'll go from there. So Andrea, I'm thinking this first one will be for you. Has RAD51C been recognized as a gene pathogen?
Yeah, so there's actually a whole group of genes that in our body work together with BRCA1 and BRCA2. You may hear the term HR or homologous repair genes. These are genes that are really important for repairing damage to the genetic material. I often talk of them as cancer protection genes, and RAD51C is a gene within that pathway. And yes, if you have a mutation in that gene that causes it not to work, it can increase the risk for certain types of cancer. And there is, as I say, a whole family of genes like that. Some of them carry slightly lower overall lifetime chances for ovarian cancer than BRCA 1 and 2, but still usually quite a bit higher than that average woman's risk of 1 in 100.
So this is a another question probably for you, Andrea. Can the BRCA gene skip a generation? My maternal mother had breast cancer, but never got genetic testing. My father also had prostate cancer. This person has been tested and is negative, but would it be recommended that my brother and my mother get tested?
Yeah, that's a great question. So the gene never skips a generation. It either gets passed on or not. We all have 2 copies of the gene. I sometimes very lightly talk at them like a pair of socks, for example. So we get 1 copy from our mom and 1 copy from our dad. And most people have 2 working copies of the gene, but when there's a mutation found, it's almost like you have a hole in 1 copy of the sock. So when somebody has a mutation, they have a 50-50 chance to pass on either their good copy of the gene or not. And so that gene can't ever skip over top of someone. So if grandma has it and they don't pass it on, to mom, then mom doesn't have it to give. You can't give something that you don't have. But sometimes in a family, it can look like the cancer skipping a generation because not everybody with the gene mutation will get cancer. So sometimes when we're drawing a family tree and we're looking at it, you'll see cases where there's cancer in one generation, none in the next, and then in the following one there is. And when we do the testing, we can often see that that gene has been passed down, just not everybody got cancer. So what I would always say is, I'm sorry, I lost track of your exact family, but if you've been seen by a genetic counselor, I would certainly suggest touching base with them to see if other people would be recommended to have testing. But in a family, if one sibling, has the mutation, then their siblings have a 50-50 chance as well. It's not a guarantee that they will have it. And the other important reason to reach out is if, it's been a long time since your family's had testing, maybe they were tested in the past and they didn't find anything. As I say, the techniques have got a lot better. Or if there's a change to your family history. So cancers, certain ones like breast cancer can be pretty common, but if there's something new that wasn't in your family before, it's always worth reaching out again and having your genetic counselor look over the file.
So kind of a follow-up question to that is, what then would the requirements be to see a genetic counselor, and can you self-refer?
Yeah, that's different in every province. It's a bit of a theme here. I would say in most provinces, the process of starting genetic testing in a family usually starts with somebody who's had cancer. So we've been talking a lot about ovarian cancer, and I would say that's pretty uniform across the country, that if you have an ovarian cancer diagnosis, you probably qualify for genetic testing. But once it's been determined that there's a gene mutation in your family, then that also is an option for people, whether they've had cancer or not, to get testing. So that's going to look a little different in each province. Many provinces have gone towards accepting self-referrals as long as you have a letter or something from your family member's genetic clinic to say that there's a mutation found. But some clinics may still require you to get a referral from your healthcare provider, and that's usually your family doctor or a nurse practitioner or another specialist.
Thank you. I know it's hard when the guidelines are different from, like I said, province to province, region to region. So thank you for that. Mm-hmm. This is a question for Nicole and Noreen. And this person is just wondering how it must be so overwhelming to decide what to do and when to do it, especially, Noreen, in your situation when you're moving from province to province and the guidelines might be different from here to there. What helps you in making some of those decisions?
I can start. So I think for me, for preventative surgery, it's easy because I see my Aunt Sherry. I know about my mom's cousin, and I see what my mom's doing. So when I think about myself, I want the preventative surgeries because I've seen the worst case scenario. And another thing too is right now, that being said, I still have those questions. Well, with the screenings, especially with breast cancer, I've been told that the rates, yes, I could develop cancer, but it be caught early enough. But then whenever I tell myself, like, yes, it could be caught early enough, but then that still means surgery and chemo and treatment. So why would I want to do another step? So it's just a question of whether and when that will fit into my life and when I'm going to get them. And I still don't have those answers. I have a few years at least to think about it. I try not to put pressure on myself either, because I think if you can get trapped in that thought of like, when should I do it? When should I do it? When should I do it? So I think it's just taking it day by day and making sure that you have the most information possible. And that's what I'm still going through. I'm still talking to, I actually have an appointment booked with my breast cancer doctor at the end of the month. And it's just to go over those questions about when a good time is even for me to get preventative surgery. So yeah, still every day, it's in the back of my head. Sometimes I forget I even have it. I just live my life and I'm going and I'm like, oh, right. Yes, I do have this thing I need to be thinking about. But yeah, it's always in the back of your head.
Noreen, anything to add?
Yeah, I mean, I think, this has sort of been like front of mind for me in the past 2 years as I've kind of made a lot of the decisions. And I think that when I was a bit further from the decisions, it was easy for me, like being someone in healthcare, to kind of be a bit more of the maybe proactive approach or surgical approach, where I thought, yeah, those are things I'm going to do, but it always was kind of far off. And then all of a sudden I turned 25 and now I'm 29. So it's definitely not, they're definitely like not easy decisions. And I think, just identifying, I think Alicia put it in the group chat and other people were, and Andrea was talking about it too, but like not everyone with a gene mutation will get cancer. And I think that's what makes like our decision so difficult, is it's all, like I was talking about with my job, like risk assessments. And a lot of it is like, how comfortable are you with uncertainty? Because none of us know like how old we're going to be. We, just saw this, the woman who spoke before us, and she's so young when she was diagnosed. And, then you think about, oh my God, timing. And so everyone's going to have different experiences, and none of us can control everything. So it's tough, and it's just weighing those things. What's your comfort? For me, it was starting breast screening and seeing how that went for me. How did it feel like waiting for the next test, or how did it feel getting something that they flagged and waiting for the follow-up scan? So you just have to see, like, I wanted to see, is it something that I'm going to be thinking about all the time? Will I be anxious about it? Or could I just go through every 6-month screening and sit with that? And if it wouldn't impact me much, maybe I'd do it for longer. So yeah, they're tough decisions, and going through it is definitely not easy. And I wish Arlene the best with, when it's coming up, like it's a huge anxiety, especially when you don't have something you're treating. It's not as easy, not that that's easy at all, and comes with way more horrible things, I think, than we have to go through. But it's still like going through a major surgery when you're not, when you're preventing something that's not there yet, is definitely hard. Yeah, the what ifs. It's hard psychologically. But it is, it is amazing. We have the knowledge now and the opportunities, but it's definitely they're definitely huge decisions, and they come with their own losses and grief. That maybe why we call it a Previver, because it's not the same as surviving cancer or having to go through that, but it is going through your own like losses that if we didn't have this, we wouldn't have to deal with,
And I'm seeing a lot of similarities with our first session that we had earlier today as well. And I think just the fact that we talked about a little bit earlier too, is that there really is no one size fits all answer, and what might be right for you might not be right for Nicole, or might not be right for someone else. And just finding as much information as you can that you're comfortable with your decision. So thank you both for answering that. I have time for one more question. And Andrea, this one's going to go back to you as well. And it's another question that we get a lot. If a patient or if a person doesn't meet the criteria for genetic testing, but wants to get tested, what would you advise? Or what are your opinions on using services that we would pay for?
Yeah, that's a great question. And actually, I don't know if Alicia Tone wants to weigh in too. There's been a lot of changes and growth. So one of the first things I would do is definitely reach out to the genetic clinic to make sure they got the right information, because sometimes that's part of the problem. We're all busy with care providers, and sometimes the right information hasn't been provided with the referral. So I definitely would reach out if you think there's something missing or that all the information wasn't provided. Sometimes that does make the difference. For people who don't, and often this comes down to a situation where there has been a case of ovarian cancer in the family or multiple cases, and there's no living relatives available to do the testing. And that's the case in Saskatchewan, where we may not have the ability to offer the testing. The cost of private pay testing has come down a lot. You just have to be really careful about the lab that you're using. So again, a lot of genetic clinics will provide some guidance on reputable labs, and there are a number of them. The risk of the testing, as long as you're using a reputable lab, comes down to how we use the information. So if a genetic cause is found, a mutation on one of the genes, that's pretty clear cut most of the time. But if there's no mutation found, kind of how we interpret that and what that says about our risk to develop cancer still has to be interpreted pretty carefully in the context of your family history. So we often say, if you don't have cancer, you've done a testing and it's negative, it shouldn't take away the need for important screening like breast cancer screening if there's a family history of cancer still. And I'm sorry, that's not maybe as concise as you're looking for, but there's a lot of different private genetic testing options out there, and it's certainly come down in cost. And I see Alicia's thing. So the Prevent Ovarian Cancer program was amazing. And I know in Ontario, I don't know if it's actually still going, I shouldn't overspeak you, but the data coming out of that was amazing to say that if you do have a first degree relative with ovarian cancer, that's still probably cost effective and helpful and useful in so many ways for testing to be made available to those relatives. But it's taking that information and then elevating it up the chain to those provincial Ministry of Health to make sure that the data, affects change in the province testing programs. We're getting there, and the cost of testing's come down a lot. When I started doing this, we were talking about, $6,000 to do private pay testing, but it really has come down into the several hundreds of dollars now. So.
Awesome. Thank you for that. And thank you, Alicia, too, for chiming in on that one. Appreciate it. So that is all the time that we have for our session tonight. Just like the last one, I feel like we could continue this conversation, keep going, but I wanted to thank you all so much for sharing your personal stories and experiences with us and your expertise. We truly appreciate it. And I just want to take the time to wish you all the best of luck. I know a couple of you have more surgeries coming up and some treatments, so we wish you all the best of luck with that.